Hello and welcome everyone. I am Tina Walia and I'm delighted to be your host today. Continuing our health and wellness journey with webinar Demystifying Depression. Our distinguished speaker, Dr. Kukreja, will shed light on the complexities and management of depression. The webinar is being recorded and the recording will be available to those who have registered. The Ripple Effect Wellness Organization, or TRIVO, was founded by Dr. Sudhi Devanesen and Mr. Ravi Juneja in 2009. TRIVO's mission is to create healthy communities through education. One of our main goals is to inspire change at a personal level. Think of it as a ripple effect, a drop of information that challenges the status quo and spreads in ever-widening circles to make a positive influence and generate significant results. The Webinar Outreach Wing, or WOW, is a branch of TRIVO, and we have been serving our community for well over 6 years. We host a number of webinars throughout the year by inviting leading medical experts to empower and educate our audience. And now I'd like to talk about our outreach. We have attendees from different parts of the world: Asia, Europe, Australia, and North America. With every single webinar we conduct, we are reaching new people from different walks of life and essentially proudly growing our outreach. Thank you so much, audience, for increasing our outreach. Dr. Sudhi Devanesen is president of the Ripple Effect Wellness Organization. He is a family medicine physician, an educator, and a public health activist. He was inducted as a member of the Order of Canada in 2001 for his role in health and prevention of heart disease among South Asians. He has also been the chief of Department of Family and Community Medicine at St. Michael's Hospital. It is my honor to introduce Dr. Sudhi Devanesen.
Thank you very much, Tina, for that introduction. And welcome everybody to this very interesting webinar. And I thank Dr. Kukreja for accepting our invitation to speak tonight. A wonderful event happened on April the 10th when we presented a check to the Trillium Health Partners, and in particular to the Department of Geriatrics and their falls prevention program. And here you see our group of executives and volunteers of TRIVO who have gathered together to make this presentation. And I want to thank them and for all the effort and work they put in every event, for every webinar, and for any special events. Our volunteers are outstanding, and I'm so grateful to them. There are some exciting developments that TRIVO is going to be launching. One of them is Health Lit for young executives and young professionals, and that launch has taken place, and their first links will be out for the public very soon. The other one is a program called Impact, which will be again launched very quickly and very soon once we get the funding for it. This will be for mental health among the youth. And we do have some other wonderful possibilities of expanding our work with Roofs for the Roofless in India and increasing the number of scholarships. And again, I do want to thank Dr. Mangi and Neil Godara for leading those two wonderful programs that we have put forward. The WOW team, the webinar outreach team, has worked extremely hard. And although our chairperson is not here, Smita, they have filled in that gap and maintained a very high standard and brought together this webinar, and I thank them for doing this. Thank you very much. So today, I want to introduce a new word. In this world of tension, anxiety, and stress, and speed, and a lot of anguish, I feel, there is a wonderful noun called keyif. Keyif. It's a Turkish word. And what this word means is to delight in moments of enchantment, euphoria, and tranquil relaxation in the middle of your busyness. In other words, it's a healing moment or a mindful moment where one can escape the troubles of the world even momentarily and get that moment of inspiration, rest, tranquility, where the brain is empty of all thought, all work, all lists, things to be done, etc., and anxieties. So the word kif, Keyif from Turkey. So that's my word for you. Please practice this in your day-to-day life. Moments of tranquility, delight, enchantment, euphoria, and relaxation. Thank you very much. And back to you, Tina.
Thank you, Dr. Sudhi, for continuing to enrich our vocabulary with this new word, cave. I would like to remind the audience about the Q&A session at the end of the presentation. Before I introduce our distinguished speakers tonight, please answer the simple poll, which will only take a few seconds of your time. This will provide an insight into our audience today. First question is, do you have a family member dealing with depression? Second question, are you concerned about depression? And the third one is, are there any health professionals in the audience caring for people with depression? Thank you so much, audience members, for answering this poll. It is my pleasure today to introduce our keynote speaker, Dr. Kanwal Kukreja. Dr. Kukreja is a psychiatrist, a clinician, educator, and an assistant clinical professor at McMaster University's Department of Psychiatry and Behavioral Neurosciences. He's worked both inpatient and outpatient at Homewood Health Center, Guelph, Grand River Hospital, Kitchener, and Oakville Memorial Hospitals and Providence Care, Kingston. His specialty is using short-term psychodynamic psychotherapy and mindfulness for individual and group therapy. Sharing the stage today with Dr. Kukreja is our very own WOW executive team member, Dr. Asha Devanesen. Dr. Asha Devanesen is an emeritus of the College of Physicians and Surgeons of Ontario 2018. She's been practicing family medicine in Mississauga at the Department of Family Medicine at Credit Valley Hospital. She was president of the Medical Staff Association and was also on the hospital board for 4 years. She's been a consultant for the Peel Board of Education for children with learning problems. She's also the founder of Sharing and Learning Together, a Bible study program for adults with intellectual and physical disabilities for 28 years. She's been a community advocate for Women's Outreach Wing of Trevo since 2018. A very warm welcome to both of you, Dr. Kanwal Kukreja and Dr. Asha Devanesen. And Dr. Asha will discuss her patients with Dr. Kukreja. Over to you. The floor is yours. Thank you.
Thank you. Dr. Kukreja, I first want to thank you from our heart that we have a psychiatrist who is giving this talk to our people. So thank you very, very much. I would like you to please help us to demystify the terminology called depression. And by the way, this topic was chosen by our audience in our previous webinars. So, is it a loneliness that seniors feel when they live alone? Is it anxiety about your teenagers that may not be reaching their goals? Is it a feeling of low because you're not getting along with your relationship with significant others? Is it a fleeting feeling? Or is it there to stay? And if it is there to stay, then does it always show a sadness? I'm going to share the story of two of my patients that shows that depression is the greatest mimicker. So, my first patient is DM, a 40-year-old gentleman whose chief complaint was that he was extremely upset because he had a very poor review at work. He wants to leave a note for work for 4 weeks as he's finding it difficult to cope with his workload. He thinks he should look for another job.
Thank you, Dr. Asha Devanesen and Dr. Sudhi Devanesen, as well as all the team members of Trevo. I have known about you, attended a couple of gala events, and have always been impressed by the kind of work you do, the strength that you build in the community with that, and your unwavering energies. So thank you very much. Dr. Devanesen, this is an interesting patient who it seems has been told that he is having some problems. And that's one of the interesting features of depression, is that people themselves may not be able to recognize that they are unwell. And it may be either a family member or a physician or a coworker who may actually share that with them, or they may get into problem while they are at work or at home. And it is also a self-perception problem. And we'll talk about that in a hopefully
So he feels hopeless and helpless at work. This makes him feel very guilty. He thinks it's the work culture, expecting too much from the staff.
Yeah, those features of hopelessness and helplessness and the sense of feeling guilt, along with the lack of interest in things that the person is used to doing, as well as uh, losing interest in sex or in eating, um, even like the daily activities may get affected. So I think it's important to further evaluate this person.
So I did look more into his complaint. He has no reprieve at home either. His wife has been complaining about his non-participation in parental duties. He feels exhausted all the time. He has no energy to take kids for their hockey games. He thinks it could be from lack of sleep, as he wakes up at 3 a.m. and is unable to fall asleep. He has lost 5 kgs, though he is eating okay. He is blaming his recurring abdominal pain for it. He doesn't understand why he feels sad in the evening at home. The other night, he woke up and was sure that there were people snooping around their home. His wife could not hear a sound.
I think that is a excellent history that you've been able to get from this patient. And the first thing that comes to my mind is that there is a social and functional impairment, which is necessary uh, for a diagnosis of depression. It's not just sadness or um, or which can be temporary, or it can be longer standing too, but it has to be affecting their social and functional life, which in this gentleman's case is. And um, sleep has a very interesting relationship to depression. And why I say that is because a lack of sleep or insomnia, as this person is having, can lead to depression or complicate depression. And similarly, depression itself can do the other way around, like it can worsen sleep issues.
Yeah.
Now, the fact that he's lost 5 kilos of weight, depending on how tall or short he is something that will also have to be looked at. And we need to always look at medical reasons for what the symptoms may be. And
Yes.
that and recurring abdominal pain is also another issue that we don't generally look at it, but there is actually a gut brain connection. And maybe we'll talk about that a little later. The part about the snooping that he's feeling people are doing is an indicator that whatever is happening, which could be depression, it may be associated with some psychotic features. And what I mean by psychotic features or psychosis is that there is a lack of touch with reality. So people start to hear things, see things, feel that people are after them. So those kinds of symptoms indicate that his illness is moderate to severe.
Oh, I see. So he's educated. He has had an MBA. He's upper management in a bank. He's a non-smoker, non-drinker, no drug abuse. Used to play hockey, but has stopped for the last 2 months. He has hypertension, which is well controlled on medication.
Which actually leads us to something that depression doesn't discriminate between sexes or between um, educated or non-educated or in different parts of the world. So it doesn't discriminate. And so well-educated, high-achieving gentlemen like your patient can be as at risk as others. But there is some complicating factor which is based on the financial and the social environment in which people live, which does increase the risk of depression. The good part in this, your patient, is that he's not smoking, he's not using alcohol or drugs, which can always complicate, meaning they can lead to depression as well as be a coping mechanism. And the last thing I'd like to say is that a lack of interest in the things that a person is used to doing. They used to have fun playing hockey. He's not been doing that for now 2 months. And that's a long period of time, which is also one of the kind of diagnostic criteria which is like it has to go on for 2 weeks or more.
Okay. So in the family, the father abuses alcohol, the mom is healthy, the brother, the dropout from university, but managing okay at a factory job. So there's a big disparity between the two siblings. The sister, alive and well, married with husband and 2 children. On paternal side, there's a history of alcohol abuse, diabetes, kidney failure, and suicide. On the maternal side, heart disease and alcohol abuse.
So here, as you have taken a great family history, which is part of the assessment, kind of comprehensive assessment that we do, we see in your patient's case that the family, the genetic predisposition, at least to alcohol use, which can be a coping mechanism again to deal with depression, is there on it seems both sides, and which then leads us to always be aware that this could be the way that this patient starts to deal with it if he doesn't seek out treatment. The part about heart disease is also important because heart disease and depression also have a, uh, a comorbidity to it. And that is something that we'll keep in the back of our mind as we look at treating this person.
So when I examined this person, his affect was flat. That means he had no emotions on his face. His blood pressure was normal. His pulse was a bit high, but that is fine. His breathing, again, was normal. His weight was 65 kgs. And as you questioned, his height was 6 feet 1 inch. So it was low for his height. The rest of the examination was normal.
So this is part of the examination that we would do as a comprehensive assessment. And one of the features is this flat affect that you found in your patient's case. A flat affect may not only be a feature of depression, it can be a feature of some other mental illnesses too, but something that is quite common in patients because basically it's the emotional kind of numbing that has happened and doesn't allow them to be able to express emotions well. As you mentioned, the weight is low, especially when you see the height. And we always have to be careful about any kind of medical causes that may be contributing to this person's illness. We always keep kind of in the track of that we don't miss any medical causes because those are treatable.
So I made a diagnosis of mood disorder and weight loss that had yet not been diagnosed.
I think that's a good differential diagnosis to kind of go further in your patient's case.
So, being his family physician, I investigated him for weight loss. I did a blood test, urine, vitamin D and B12 levels, stool for occult blood, that is hidden blood, to rule out colon cancer, chest X-ray and ECG. And to diagnose his mood depression, I assessed it by using some tools that are available to us in our practices and for our patients. And I made a diagnosis of major depressive disorder and gave him a leave note for 4 weeks because I knew he would need that time for him to take his medications and for me to know that he is responding to it.
Well, that is a wonderful workup that you've done. which would be something that I would be looking at as a psychiatrist if this person was to be under my care. So thanks to you, and I always am so in awe of family doctors because you are dealing with all kinds of patients and still are able to do great work. And so kudos to you. This thing about the 4 weeks, I think is very important what you did, because a lot of these patients may themselves or their families may say, oh, gird up your socks and go out, or like go to the temple or the mosque or the church, and then or sometimes when people are younger, they'll say, oh, you get them married and then they'll be fine. So there are many ways in which people cope with these kinds of uh, uh, problems, but giving them time to actually start the treatment, and for you to be able to assess the uh, benefit or any kind of side effects that may be occurring from. I think this is a great workup. Now, I also, and we'll probably have to touch on that, because I mentioned about the psychosis or the lack of touch with reality. This your patient actually falls in the moderate to severe range, and for you, for that's one of the three options that we have to think of, is whether this person can be treated by you in your office or by you with a multidisciplinary team, or does he need hospitalization? In my opinion, from whatever I've seen, I think he needs to be at least assessed in the hospital by a psychiatrist or in the emergency unit.
Okay, well, I managed him as an outpatient. Maybe it was because I managed him as an outpatient, basically, and he did well. So now this is my second patient, MM, 36-year-old, and she came to my office with palpitations and excessive anxiety.
Yeah, as you said, depression can be a great mimicker. And now, if you look at this person's presentation, it's not typical presentation that we would think of. But excessive anxiety can be actually one of the ways in which people with depression can present. Um, the other thing I want to thank whoever made this slide is, if you look at what this young woman is looking out at, you see different hues of gray, kind of blocking out all the blue sky. And that's just the kind of a feeling that patients have when they have depression, is that blue sky that used to be there is no longer available to them. And they are perplexed as to what's happened, why. And different hues of grays can take over.
So Tina, our MC, she has made all the slides.
Excellent.
So we are very fortunate to have her in our team to do this for us. Her anxiety had been progressively getting worse, both at work and home, for the past 4 weeks. Today, when she started having palpitations at work, she came to see me, concerned that it was her heart.
Well, that's an interesting um, issue, which is the stigma that depression may have around it. And for people to be able to say that they want to be assessed whether they are depressed can be difficult. And it may have cultural overtones, undertones, or socio-economic undertones. So that's something we have to be aware of. The other part is about the 4-week interval that the patient has had as the symptoms have become worse. again, going to one of the diagnostic criteria, which is a specific duration after when we can diagnose somebody with a major depressive episode. And also the fact that both work and home are actually being affected. So the functional impairment is occurring in both major places for this young woman.
So I'll tell you what is happening at work and home. She was finding coping with work more demanding. Her co-workers seemed to be talking about her all the time. She had requested a privacy screen for which she needed a medical note from me. And at home, she started pacing the floor at night, worrying about work as she had taken on too many projects at the same time. Fortunately, her husband had taken over her home commitments. According to him, she was overspending money. She was forgetting the children's after-school schedule of activities.
So, as you can see, this patient presents quite differently than your first patient. And
Yes.
a lot of anxiety symptoms, like the pacing the floor at night or worrying about work. And there are a couple of things that stand out in this. One being that she feels that her co-workers are talking about her all the time, which again, we have to do some more digging and find out whether this actually is a psychotic symptom. The other thing is, which her husband, which you could get the history from her husband, is that she's overspending money. And then, as you share these things with me, I start to wonder whether there is the possibility of the opposite of major depressive episode, which is mania or hypomania, which can actually go hidden in patients with major depressive disorder and needs a very different kind of treatment. And so, therefore, it's very important whenever we are thinking of the possibility of depression, we always consider whether there is any history that indicates hypomania or mania. The last part is about her um, being so ill that she's forgetting the children. And that can be serious and have serious uh, complications with that.
She's also a university graduate. She's a senior manager at insurance company. She's a non-smoker, just a social drinker, in a healthy marriage for 15 years. Husband has a job and is in good health. She has two lovely daughters, 10 and 8 years old.
Which tells us that she is a very productive member of society, and that not only is she actually working full time, but she's also working another shift at home, which a lot of women do actually, right? Now, the part about the marriage and that things have been okay till now is an interesting one because it also has something to do with the age of onset of, and we'll maybe talk about that a little later. But the fact that she is in a healthy marriage, actually, relationships can be a protective factor, and loneliness can be a risk factor for depression. So that's something that's coming to my mind.
So the parents were separated due to mother's depression. The brother is healthy but abuses marijuana. There is no family history of heart disease. The rest is nil significant.
Well, this kind of points towards the treatment options for this person when we are thinking of it. Because when I hear parents separated due to mother's depression, you can imagine when this young lady was a baby and her mother may have been depressed at that time, what kind of attachment issues may happen. And then if the parents separate, children may actually take on that responsibility that they are somehow to blame for their parents separating. And that can be not aware to the patient, to the child, and then as they grow older. But that is something that we will look at when we engage, hopefully, in psychotherapy. That possibly should be helpful. The other thing is about the marijuana with the brother. So something again, a history of that is some that we are going to be aware of as a coping mechanism that this patient may engage in because of the genetic possible risk.
Very common in family practice.
Mhm.
So on examination, she looked anxious. I can still remember her. Her blood pressure was 150/72. The pulse was high, 140. Her breathing was rapid, and the rest of the examination was normal.
Which is which goes to show the fact that she is a healthy woman otherwise, but you can see that her blood pressure is high and her respiratory rate, so her anxiety level is quite significant. And that can be an indication. Earlier, many years ago, we used to differentiate as to the kind of depression. So some kinds of depression were seen to be more anxiety focused. Some could be like where there's significant anhedonia, meaning a lack of interest in things. Occasionally, people would just go into what's called as catatonia, which would be that they could stop moving or stop moving some of their limbs. And then, of course, the psychotic. So this, again, starts to give us an indication of where the treatment in this person we'll have to look at is to treat the anxiety and the underlying mood disorder, which is again starting to we have to keep the option of diagnosis of bipolar disorder open.
Okay. So I made a diagnosis of tachycardia, that means a high pulse rate, with systolic hypertension, meaning that 150 is high, but 72 is normal. Anxiety with paranoia, affecting her activities of daily living.
Yeah, I think that is a very significant indicator that the activities of daily living have started to be affected, because these are very basic things that all of us are able to do most of our lives. And the other thing is, at this point, of course, the diagnosis of anxiety with paranoia is good. The only thing is that the anxiety and paranoia, they can co-occur, but it still needs some investigation to see why she is paranoid.
Yeah. This anxiety was because she was presenting as anxious, not an
Mhm.
anxiety disorder.
Right, right.
So I referred her to the emergency at the hospital because she needed a cardiac as well as a psychological assessment.
I think that's a great management plan, which I totally agree with, because we have to do a further comprehensive psychiatric assessment. And as you rightly said, a cardiac assessment, again, keeping in mind medical causes. I think that's a great management plan. Thank you.
So she was admitted.
Mm.
And while she was in hospital, they did all kinds of testing, of course, and treated her and made a diagnosis of manic depressive illness.
Yeah, I think so. Our suspicion was kind of right, and the important part in that is when a diagnosis of manic depressive illness is there, then we have to be very careful about the use of antidepressants, because sometimes antidepressants can kind of turn people over into having hypomania or mania. So these patients with the manic depressive episode or illness will require some things what we call as mood stabilizers. So
Yeah,
that's
so
why
they
this is
tried
so
out her
important.
medications in hospital. So when
Okay,
she was discharged, I could manage it.
excellent.
Yeah. So, Dr. Kukreja, I shared my two feel good stories with you because both the people did well and they continued to lead very productive life. And I'm now looking forward to you sharing some pearls of wisdom about some more things about depression.
So thank you very much, Dr. Devanesen, and for introducing us to these two lovely people who are quite distressed, and for doing such great workups, as well as sending them to the right treatment options. Um, I'm not sure whether I'll have much pearls, but I certainly will try to. Next slide. Um, look at whether and what do I hope to achieve with you all in the audience is that the diagnosis of depression is like any other illness's diagnosis. And so that after our little conversation, again, in the few minutes that I have, obviously I won't be able to cover different aspects of mood disorders, but I'll point out a few relevant ideas that I think may be helpful to the audience. And I also want you to go away with the idea that depression is treatable, though it can become recurrent, and therefore we may look at possibly treating some patients for a much longer period of time. So next slide, please. This is the kind of the scope of what we are dealing with. So if you look at that figure of 300 million individuals worldwide in 2020 who are living with a major depressive disorder. So you can imagine 300 million individuals and their families and their communities in which they're living, and what kind of disability that they would be feeling and having to deal with, the loss of productivity. So this is actually depression is the second leading medical cause of disability in the whole world, and um, about 5% of Canadians more than 12 years of age reported that they had a major depressive episode within the last year. And this climbs to 12% of Canadians reporting for a lifetime episode of major depression. And as we were highlighting the social and occupational impairment in your patients, the diminished quality of life, and the elevated risk of suicide that thankfully none of your patients had. Next slide, please. So after you've done such a good history, then or if a family member has some concerns or a co-worker has concerns, then we would get them to do, let's say, a questionnaire like a PHQ-2, and then subsequently a nine question self-reporting measure, and along with your clinical assessment and these measures. And in the older population, we may need to do a different scale because some presentations can be different. And if somebody scores positive both on your assessment as well as the questionnaires, then we would further go into a comprehensive diagnostic assessment. Next slide, please. Here, I've actually mentioned a few kind of pointers. Again, this is not a comprehensive lectures, or because I mean, mood disorder we usually cover in quite a few lecture series. So, but a few things that I wanted to highlight. And one is the age of onset. Now, 50% of mental illness first occurs by adolescence. Now, take that in. 50% of mental illnesses first occur by adolescence. And another 25% emerge by the mid-20s. And what is happening in the mid-20s is that the persons have started to go to college and universities. So therefore, the school system and the college and university systems actually have to be very good. And thankfully, we have some great services in some our universities and colleges here. The next thing is anhedonia, which is a very technical term, but basically it means like a lack of interest or lack of enjoyment. And so therefore the person may not come to you saying, oh, I'm depressed. They may say, well, I used to do all these things and now I don't feel like I can't. And their family members may also corroborate that. The third thing is about perception. Now, as we start from being a baby to becoming an adolescent, and then young adult and adulthood, we are at all those times starting to develop a sense of who we are. I am, right? When I start to say, I am this, my wishes are this. So that self-perception, that sense of being this person starts to be affected when people have major depressive disorder. And hopelessness and helplessness can be a frequent presentation, which then may lead to the possibility of suicidal ideation, meaning ideas and person doing things that may end up harming them. The fifth part was a very interesting thing that came to my mind. Somebody was recently during the election saying, well, Canada needs to be the wealthiest middle class in the whole world, and we have the capacity to do it. And my initial reaction to that was, should we be talking about the wealthiest or should we be talking about the happiest? My own kind of bias was that money does not beget happiness. And happiness is much more than just having money. But then I actually did some research, and it seems that money does, to some extent, at a particular number, does actually lead to a more happier person. Beyond a certain limit, there are questions. But this is something very interesting that I thought I would share with you. Thank you. Now, as we were talking about the scope of the problem, just a second, please. We see in 2015 to 2019 that over this almost 5-year period, the incidence of people reporting suicidal ideation has gone up from 7.7% to 11.1%, and any mental illness has gone up from 21 to 31%. Next slide, please. Depression initially was thought of as it's a Western concept because a lot of research has been done here, and the American Psychiatric Association has come up with a book which is called as the DSM, and we use that um, as a guide to help us with diagnostic improvement and also with treatment. So, but it's interesting that in other parts of the world, there may not even be a word for depression. And this study that was done in 2007, women from India, Brazil, Peru, Chile, Venezuela, Morocco, Tunisia, Serbia, Hungary, meaning we've covered Africa, we've covered South America, India, and parts of Europe. If you look at the presentation, because these patients were actually diagnosed with the depression. Now, I've highlighted a few of these, but you can see in India, a headache, backache, pain in the belly, body ache, vaginal discharge, change in taste. Or let's say in Venezuela, I'm ugly, I don't want to put makeup. I don't want sex. I don't feel like dressing up. And in Serbia, fatigue, inactivity, slowness without will. So next slide, please. And again, continuing that further, if you see, I have changed. This is the Indian version. On the verge of crying, irritable. I'm unable to perform my duties. And in Venezuela, it would be, I have everything and I don't know what happened to me. And in Serbia, intolerance to noise, heat, light, outbursts of anger towards children. So the social way in which depression and mood disorders presents may be quite different, and the clinician has to be open to recognizing that there are cultural differences in the way major depressive disorder presents. And even if they don't have the cultural competency of a particular patient's culture, then to ask the patient to get more family input. Next slide, please. Here are some of the risk factors that we have to be aware of. So as we saw in your patient, recent onset anxiety, or let's say a recurrent or prolonged hospitalization, diagnosis of dementia. Recently bereaved is a very important aspect, and which can lead to major depressive disorder. And as you see, social isolation is also in there. And therefore, more and more we are seeing that the more we are with our computers and our phones, and lesser and lesser social interactions starting from very young onwards. So we have to be cognizant of that, and we have to ask our governments and other organizations to look at whether we are going towards more and more social isolation, which then causes mental illnesses and disability, as we saw. Next slide, please. Now, we were talking about severity of depression, and here I'll just point to you that there's a whole gamut of how depression may present. And one may be that only the functioning is affected, but the patient may not have all those symptoms that we saw, lack of sleep or appetite disturbance, or not wanting to have sex and not being able to do their work. And then it goes towards the right side, where severe major depressive disorder would be that most of the symptoms, there are 9 that we have and the patient is significantly impaired, and that psychotic symptoms that we were mentioning is also an indicator of severe depression, which then is then going to lead to treatment options. Now, it's not that one thing leads to depression. It's usually a downward spiral. And we've talked about genetics. Excuse me. I was not feeling the best for 1 week, and some of that is lingering. But if you see in the genetic risk, 3 times the risk of depression if there's a family member. And if you look down the last 3, these are stressful events, death of loved ones, early childhood adverse events. This is a very important aspect, especially with all the wars that are going on and how that would affect the families, the communities, the children. And then you see trauma, divorce, loneliness, getting older. And in addition, if there are some medical conditions, which thankfully both of your patients did not have significant except for the hypertension, then that can also further cause this downward spiral. And as we mentioned, living in difficult social and economic circumstances. Next slide, please. This is something that, again, we've kind of mentioned, but it's important to recognize the gravity of this, not to be frightened by it, but to be aware of it. And we have to be aware that that risk of suicide attempts in individuals with the major depressive disorder is 5-fold higher than in the general population. And 4,000 suicide deaths happen per year, more in males than in females. The thing there is that females may make more suicidal attempts or have other self-harm behaviors, but they may not engage in activities that would lead to like the person dying. And some of those is part of the history that we would get. Now, it's also important to recognize that all those people who die by suicide are not having major depressive disorder. As you see, only half suffer from major depressive disorder. They may have other mental illnesses that may be contributing. And manic depressive disorder, which can frequently have anxiety or substance abuse and impulsivity, that can then suddenly the brakes are off, and then the person's usual cognitive aspect is gone, and then they may impulsively act out on. So what that means is that there is no short way for anybody to be certain that this person will or will not. And even physicians and psychologists, the research has shown that we may not be much better than the general population and or family doctors in assessing this, just because it is so difficult to predict. Next slide, please. Now, like tagging on to what I just said, what would tell us that that we have to be extra careful? So when there is a well-developed plan or an intent to act, so if somebody has a gun, they're planning to go to the bridge to jump off it, things that cannot be reversed. There is a hopelessness or anxiety and impulsivity and stressful life events that are happening, as was starting to happen in both your patients. Now, the other things we need to aware of is it takes a village. So what I mean by that is, what do we do when a person is being diagnosed with major depressive disorder is to, first of all, identify the warning signs. And that can include thoughts and feelings, which we also call as emotions, and what are the circumstances. Then self-management, then distraction and connecting with people, going for walks, using supports online, engaging in social and community supports, also having a list of professional contacts, including crisis lines, urgent care clinics, and then to make the environment safe, which includes all those that are mentioned. These are some of the treatment options. And for mild depression, self-help, exercise, light therapy, um, some of these can be very helpful. But when it starts to get into the moderate, severe, and again, we always keep track of what the social situation is. Now, thankfully, in both your patients, both of them were married, both of them had supportive families. But if somebody is having major depressive episode and is living alone or has just lost somebody, the risk between those two would be more for the person who is not having those kinds of supports. So medications and psychotherapy, the combination of that actually has been seen to be beneficial for at least this moderate to severe, more so the severe. Um, and Also, then there is the aspect about how physical activity, as I mentioned, sleep hygiene is very important. And this last part I want to highlight is the sunshine and light therapy. In our country, that's one of the things that can actually predispose people to having depression, especially what we call as SAD, which is more associated with the lack of light that we have. So I think that's very important. Now, this is, if you see on the left-hand side, it's first line. On the right-hand side, it says level of evidence. And so lifestyle interventions that you can do, supervised exercise, and then light therapy of a particular kind. And next slide, please. I just also wanted to mention about the gut-brain axis, which a lot of work has been done in the last almost like 20 years, where there is a significant correlation between the gut and the brain, because both the brain and the gut have produced neurotransmitters. And therefore, you may find a lot of patients coming up with gut symptoms, but they may also be an indicator of mood disorders. Next. Now, here I mentioned this very interesting concept, which I actually use as part of my psychotherapeutic interventions. And that is this concept of the unconscious mind. If you see on the right-hand side, there are thoughts and perceptions. But these are the parts that we are conscious of. The pre-conscious is the things that we could be aware of if we wanted to or tried. And that can sometimes be helped by mindfulness, meditation, etc. But that's where some of the memories and the stored knowledge is. And we may sometimes be able to bring it up, but sometimes it doesn't. But a major part of our mind is actually unconscious. And so these are things that we are unaware of and cannot become aware of until unless we engage in ways to actually uncover them. And here, those are all the fears, the wishes that can't be fulfilled, that are all stored there. Now, this is the different kinds of psychotherapies that are available. And these can be all individual and group. Nowadays, there is the internet-delivered psychotherapies also. The efficacy may not be exactly as when you're meeting a person in person or online, but they have been found to be somewhat useful. Next slide. These are just a list of medications because we need to be aware that depression can be treated with many different kinds of medications, meaning that there are different kinds of neurotransmitters that may be affected. And alongside that, we can also use some, and I know this audience, there will be the possibility of using all these complementary treatments. And the only one that has a first-line evidence is of St. John's wort, and that is only for mild depressive episode. It I also wanted to share here that this advice or whatever I'm sharing is not in a particular, that it may not apply to you. So please don't take any of this information on its own. Now, myths and facts about ECT, which is electroconvulsive therapy. A lot of people have some doubts about it, but if you see the first line, the response rate is 65 to 75% in treatment-resistant depression. And there is hardly any other treatment in the whole medical world that has such a kind of efficacy. Nowadays, the way electroconvulsive therapy is done is generally safe, well tolerated, and has very low potential for long-term cognitive effects or cardiac events. So something to be thought of. I wanted to touch on the cannabis use because that's, as Dr. Devanesen, you were saying, is a frequent thing that people are engaging in. And the research shows, and this is from very recently from our own people here in Ontario, and that is cannabis use is associated with increased depressive and manic symptoms in the general population, elevated likelihood of developing major depression and bipolar, and it negatively influences the development course and prognosis. Next slide, please. I've added here a few digital health interventions that we have evidence for. And these will be available to you, I think, as a slide or on the website. And I think almost the last is the government programs that we can all access, and these are just a few of them. And if you see 211 or 211.ca is one of them. So I would encourage you to use these. Next slide. So questions, and I'm going to end with a small little poem, or we call it a song. And what it basically says in English is, "Hey, my sad heart, listen to me. Where there is no peace, I am no longer going to live there." And this is the way it goes in Hindustani. Dukhi man mere, sun mera कहना, जहां नहीं चैना, वहां नहीं रहना. दुखी मन मेरे, sun mera कहना. So I'll leave it here. Thank you.
That was a big round of applause, Dr. Kukreja, for that wonderful singing at the end. And thank you so much for your deep dive into depression. It has been extremely insightful in so many ways for me, and I'm sure for our audience as well. I would like to invite Dr. Sudhi to moderate the Q&A session with Dr. Kukreja. And thank you, Divya Jain, for collating the questions in the background. Over to you, Dr. D and Dr. Kukreja.
Thank you, Tina, and thank you, Kanwal, for that Excellent, excellent presentation. A very, very difficult subject. And both you and Dr. Asha knitted this thing together exceedingly well. And I'm sure our audience is going to take away quite a few pearls. Actually, there was one question, but you have already answered it. And that was on the connection between marijuana, THC, and cannabinoids on depression, and what was the association. And you mentioned personality disorder, anxiety disorder, as well as major depressive orders are all associated with the use of cannabis as well as alcohol.
Yeah, and it actually increases not just the predisposition to developing them, but the trajectory of the illness also. If the person is continuing to use it, that also can be affected in both the major depressive disorder, bipolar disorder.
Thank you. Just an observation as a family doc. We know that serotonin plays a huge role, but you brought to us some information. Because of time, we couldn't talk about it, but that the gut and the brain both produce serotonin. And anything that impairs the concentration of serotonin leads to depression or mood disorders, personality disorders, etc. And that is why SADS, seasonal affective disorder, where there's not enough sunshine, or any gut disorders can impede serotonin uptake. And that is why the SSRIs work. So I'm glad that you brought us to our attention. It's a very, very important point to understand and comprehend.
Yeah.
So
thank you very much for bringing that up, and appreciate that. I just wanted to say that the research for depression and the association with the serotonin is based on the fact that medications were actually invented and tried. But I just want to add a little caution in that what recent studies in the last 10, 15 years have done, and what they've showed, especially those that have been done with dollars that are public, has indicated that only about 40 to 50% people may respond to the first line of treatment, and they may have to be tried for a long, adequate period of time at adequate doses before you making a decision about changing that to another medication or adding some other medication or psychotherapy, but also continuing with all the other the health, the food, the sleep, the exercise. Exactly.
Yeah. Well, I think you have set a new record. I think you're the only keynote speaker who actually sang for us.
Thank you. I hope I
way of
didn't jar
ending the
any
talk.
ears.
No.
But
You have a beautiful voice. Thank you very much, Dr. Kukreja, and Dr. Asha. Thank you. And now back to you, Tina.
Thank you very much, Dr. D and Dr. Kukreja. It was a pleasure to have you. And thank you so much once again. Thank you, audience, for your questions and comments. A lot of effort and hard work goes into bringing these webinars to you all. It would not be possible without our dedicated executive team who works diligently behind the scenes. I would like to thank Dr. Asha for extending our outreach by distributing the flyers and connecting with community organizations and outreach partners. Sridhar Rao for producing the webinar and tech support, Ashima Jain for running the slideshow today, and Ashna Roy for the creating and designing of our vivid and striking flyers. I would also like to thank our delightful chair, Smita Chandra, for her leadership. She's currently on a sabbatical, and we look forward to having her back for our fall webinar. A special mention to our ambassadors, Jamie Sinton, Roy Sheen, and Paul O'Hara, and Dilpreet Bansal, who work with unwavering enthusiasm to distribute our flyers. Thank you so much. Dear audience, please help us serve you better by answering this simple survey. How useful did you find this webinar on demystifying depression? Very useful, somewhat useful, not useful. First question again, how useful did you find this webinar? Very useful, somewhat useful, or not useful? How did you learn about this webinar? Email from Trivo or Dr. Asha Devanesen, from Dr. Sudhi Devanesen, from family and friends, possibly from your local library or community center, from the Sheridan College Health Clinics, city halls, or other. Third question, do you intend to attend our next webinar in October 2025? Topic is AI is in medicine. Fourth question is, what topics would you like us to present in the future? We take your feedback very seriously, and it really helps us achieve better and more far-reaching results for our audience members. We always welcome your input. In order to serve you better, we would like your suggestions about topics or speakers that you would like us to prepare the WOW webinars on. So kindly send your suggestions to info@trivo.org. If you believe in our outreach, please donate generously at www.trivo.org. Our upcoming webinar in the fall on October 2nd is about your health and AI. Should you trust it? Our popular host, Dr. Peter Lynn, is going to be back, and we look forward to having this webinar in the fall, and I hope you will all join us and spread the word and have your friends and family also take part in this webinar. On behalf of the webinar outreach wing of the Ripple Effect Wellness Organization, I would like to sincerely thank you all for attending the webinar tonight. Wishing you a safe and enjoyable summer.